from the book Treat Your Own Chronic Pain, the Chronic Pain Bible for doctors, psychologists and clients. Here I dig further into cognitive behaviour therapy, or CBT, and its variants to demonstrate that they are completely ineffective for chronic pain. Cognitive behaviour therapy has been used since the 1960s to treat a wide range of problems such as anxiety and depression, for example. In recent years, it has also been used to treat chronic pain. CBT is based on the belief that our thoughts and behaviours feed back into our nervous system and help to maintain problem states. And the theory, I put that in quotation marks because I think calling it a theory is massively over-flattering, is that it's not actually our pain, but our thoughts and behaviour that are to blame for our suffering. You'll hear a lot of well-meaning professionals proclaim, having pain doesn't mean having to suffer. Frankly, that's out of Buddhism, not science, and it annoys the hell out of me because it effectively blames people for their pain and is also patently untrue. In CBT, the psychologist seeks to identify the sorts of unhelpful thoughts and behaviours that the client has and to stop them by the use of logic and willpower and the dedicated practice of more rational or more positive self-talk. It's not surprising that there is a high dropout rate, not only among patients but also among therapists, because CBT can be perceived as deep criticism of the patient. As I said, basically blaming the patient's suffering on his or her thinking. And in any case, the results are very, very far from exciting. Let's be blunt, they're crap. After all, the aim of CBT is not to switch the pain off, but to help people accept and live with their pain, or to manage their pain, or to stop catastrophizing their pain. Good grief, I detest that awful garbage. But to be fair, CBT may not be all wrong in its theoretical basis. Studies do show that where people engage in avoidant thoughts or behaviours, their reported pain levels tend to be higher. However, we should keep in mind that correlation is not causation, and higher pain levels could readily create more avoidant thoughts and higher distress levels. This confusion of correlation with causation drives me bats. And again, I just think, how dare we blame the sufferer for their suffering? Although there are by now many studies which report glowing results for CBT, after trawling through great masses of them in an effort to find any valid evidence for CBT whatsoever, I've concluded that these studies are junk. There are so many flaws in the study designs, and the effect sizes being reported are so low in any case, or even missing altogether, that we really cannot accept these glowing conclusions at face value. We need to recognise that modern meta-analyses of CBT studies provide strong evidence that effects, if any, are extremely short-term, that these effects are to do with the quality of the therapeutic relationship with the therapist. Always nice to have a chat with a skilled therapist who has deep empathy for our situation, not due to CBT, and that CBT itself produces results not significantly different to placebo, and maybe even worse than placebo, especially when people realise they're being blamed for their own pain. Many studies conclude with statements about CBT being the gold standard, but a careful analysis shows this statement is not supported by the very data it is based on. In addition, many studies have attempted to prove superiority of CBT by comparing with inappropriate or uninformative controls, such as waiting lists or other equally ineffective treatments, such as mindfulness or analgesics, which are known to have a high failure rate, for example paracetamol. CBT only looks superior, but nevertheless still not significantly effective when compared to waiting lists or compared to things that don't work very well or that don't work at all. The Hoffman review of meta-analyses is a case in point. Hoffman first makes a claim that CBT has strong evidence, but provides data and conclusions which demonstrate that CBT in reality has a weak effect compared with waiting lists or no treatment, and is not effective in many cases. As I explained already, just about anything will provide better results than a waiting list. That's why waiting lists are not considered to be appropriate things to compare when trying to figure out if a treatment works. The Kahn Systematic Review examined several different types of treatments and found that in blind studies, all interventions, including CBT, were better than doing nothing. There's that waiting list issue again. It's amazing what a bit of human contact can do, at least temporarily. But none of these were more effective than a placebo treatment that was already known to be useless. While some people report that CBT has been helpful for them, but because every time CBT is tested properly under trial conditions it fails, I propose that it is not the CBT which was helpful, but the support of an empathetic professional with whom they had an excellent therapeutic relationship. It is generally accepted that the quality of the therapeutic liaison from the client's perspective, that is not from the therapist's perspective, is the single most important determinant of a clinically significant outcome, and that the utilisation of CBT is not a significant variable in predicting outcomes. Kuipers et al. Tried to propose that CBT could be helpful, but in the same breath bizarrely admitted that it's not been possible to show that any one therapeutic strategy is superior to any other, and that to date all studies have been correlational. Duh. Quite clearly, when we examine any of the currently utilised therapies, efficacy and effect size are similarly modest, small or nil.